Welcome to the Deep Dive, your knowledge shortcut. Really tailored for you preparing for those big orthopedic postgraduate exams.
hmm
Today, we're tackling, well, a really critical and complex scenario. Total knee replacement in a stiff valgus knee and often compounded by rheumatoid arthritis.
Yeah, tough one.
We're aiming to go beyond just the basics, really drilling down to get those high-yield, exam-ready insights you absolutely need.
In this specific situation, the valgus TKR in an RA patient, it's a real test of your comprehensive surgical thinking. It demands really careful planning, not just the mechanics.
Right, the systemic side, too.
Exactly. The systemic pathology is huge. But before we really get into the technical meat of it all, we absolutely must acknowledge our foundation for this discussion.
Okay.
This deep dive is built around the fantastic Ortho Made Simple notes. You can find them on the website mokyingren.sg.
Ah, yes, those are excellent resources.
They really are. Prepared by Dr. Mok Ying Ren. He's a top sports surgeon at National University Hospital in Singapore, and he achieved his FRCS in orthopedic surgery from Edinburgh. So, solid stuff.
Definitely. Okay, so let's start right at the beginning. Pre-op assessment. You're standing there bedside. What's the absolute must checklist on that valgus knee exam?
Right. Well, the absolute basics, first neurovascular status, always non-negotiable.
Standard.
But surgically, you're zoning in on specific constraints. First, what's the story with the medial collateral ligament, the MCL? Is it stable, lax?
Right. NCL status.
Second, is there a fixed flexion deformity? Because that really complicates your balancing act later. And third, and this is, well, arguably the most critical for safety, a really thorough check for any pre-existing common peroneal nerve palsy, CPN palsy.
Oh, the drop foot.
Exactly. If they walk in the door with a foot drop, your whole surgical goal, your correction strategy, it changes completely, drastically.
And for grading that complexity, sort of figuring out the approach, we lean on the Ranawat classification, right?
Precisely. And it's important to remember, the Ranawat system isn't just about the angle, the mechanical axis, or the femtib angle.
Right.
It's fundamentally tied to the status of that MCL we just mentioned. Is it competent? Is it shot? That finding is really what tells you if you're looking at a maybe straightforward primary or something much more complex, potentially needing revision level thinking.
Okay, let's zoom in on the RA patient then, because RA, it's not just a bit of swelling, it's systemic, inflammatory. It changes the whole game.
It really does.
What are those systemic challenges RA brings that need specific pre-op management?
Two massive things jump out: bone quality and medication management. Or vulnerability, maybe, because of that chronic inflammation and often, long-term steroid use. You have to anticipate osteopenia, poor bone quality, and that directly impacts how well your implant's going to fixate.
Makes sense. And the meds.
All right. Second, those immunosuppressive drugs. They're vital for controlling the RA itself, but perioperatively. They can be, frankly, toxic. They can dramatically increase the risk of infection, wound healing problems. It's a major concern.
Yeah, that medication protocol feels like a classic exam trap. Let's really nail this down. The antirheumatics, what's the crucial trade-off we're making?
It's exactly that, a trade-off. You're balancing suppressing the disease versus allowing the body to actually heal the surgery.
Okay.
And you need to be precise. So the non-biological DMARD, think methotrexate, azathioprine. The current advice is generally continue, though.
Continue, okay.
Yeah, the data suggests they don't significantly mess with wound healing. But the real danger zone is with the biologics, things like the TNF-alpha inhibitors. Those must be stopped, usually 2, maybe 4 weeks before surgery, because they're clearly linked to a higher infection risk. It's substantial.
Got it. Stop the biologics. And we can't forget the neck, can we? In RA, C-spine instability is a definite risk, so anesthesia needs a heads up early.
Oh, absolutely critical. That potential instability might mean they need special handling. Maybe fiber optic intubation, or considering regional anesthesia options. Anything to avoid a catastrophic spinal cord injury during positioning or intubation.
Wow.
It really is a whole system patient management challenge, not just the knee.
So here's something interesting, though, from the registry data, like the AOJ NRR. Apparently, while OA knees might do slightly better right out of the gate, revision-wise.
Yeah, in the first few months.
Right. But after about 9 months, the RA knees actually seem to have a lower revision rate compared to OA knees. Any thoughts on why that long-term durability difference?
Well, it's a bit surprising, isn't it? The hypothesis is often that the RA patient group tends to be managed more closely. They see specialists regularly for their systemic disease.
Right, more follow-up.
Exactly. Which might translate into better long-term monitoring and, sticking to the plan. Plus, sometimes the pathology itself, the inflammation, can lead to less dense, maybe a less stiff scar tissue around the joint after surgery compared to your classic stiff OA knee. Just a theory, though.
Interesting. Okay, let's shift gears. Intraoperatively, let's talk strategy inside the OR.
Yeah.
Because of that expected osteopenia, the dodgy bone, and the unpredictable joint destruction in ORA, we often get pushed beyond standard primary implants, don't we?
That's exactly right. The big variable is the posterior cruciate ligament, the PCL. Its integrity is just unpredictable in these cases.
So you can't rely on it.
You really can't. So your standard plan, your default, should probably be a posterior stabilized knee, a PS knee. But, and this is crucial, you absolutely must be prepared to escalate.
Escalate how?
To a constrained condylar knee, a CCK, or maybe even a full hinged knee implant. It all depends on the stability you find once you're in there.
And if you do have to go to those higher constraint options, the CCK or the hinge, why are stemmed components basically mandatory? What are you trying to achieve with those stems?
It's all about compensating for that poor bone stock we mentioned.
Okay.
The stems, they massively increase the surface area where the implant contacts the bone implant interface.
Right.
And that helps spread the load out, reducing stress, and hopefully mitigating the risk of the implant loosening, or even worse, causing a paraprosthetic fracture because the bone is just too weak.
Gotcha. Okay, bone cuts. Valgus knees mess with our usual plan here, too. Normally, distal femur, we're thinking maybe a 6-degree valgus cut. How does that change in a valgus knee and why?
Yeah, you definitely dial that back. Often aiming for maybe 4 degrees of valgus in the cut.
Only 4 degrees. Why less?
Simple reason, really. The lateral soft tissues are already tight in a valgus knee. If you cut the standard 6 degrees, you risk overcorrecting the knee into varus. And that increases the stretch on the CPN, the nerve, and also puts way too much strain on the medial side. You could end up causing medial failure down the line.
Right. And for setting the rotation of the femur, what landmark do we trust for the AP femoral cuts? Because the usual posterior condylar line isn't reliable here, is it?
No, not really reliable. You need to prioritize Whiteside's line, or you could use the transepicondylar axis.
Right side's line. Okay. Why is the posterior condylar line dodgy?
Because in chronic valgus deformity, especially with RA, that lateral femoral condyle is often underdeveloped. It's hypoplastic.
Smaller, eroded.
Exactly. It's smaller, maybe eroded away. So if you reference off that, you skew your measurement, and you can easily end up putting the femoral component in internal rotation, which is bad news for tracking and stability. Whiteside's line is just a more consistent, stable landmark in these knees. And, before we really jump into the soft tissue release, which is kind of the main event here,
Yeah, the crucial part.
it's probably worth just quickly mentioning again, as it's detailed so well in those ortho-made simple notes from mokyingren.sg, that even getting into the joint, the surgical approach itself, has its own unique hurdles in these valgus RA cases.
Absolutely right. Good point. The approach details are definitely high yield. We usually go for a standard medial parapatellar approach, yeah. But getting the patella to flip over, patellar reversion, that can be a real struggle because everything on the lateral side is so tight from the chronic deformity.
Exactly. Chronic capsular contracture.
So what are the backup plans? The extensile techniques we need to have in our back pocket.
You've got to be ready with a few options. There's the rectus snip, maybe a VY, quadriceps turned down, or if things are really stuck, even a tibial tubercle osteotomy.
TTO, okay.
But, and this is a critical warning, when you've used that medial approach, be extremely cautious about doing an aggressive lateral release.
Why is that?
Because your medial incision has already potentially compromised the blood supply coming from the medial side of the patella. If you then go and aggressively release laterally, you risk cutting off the remaining blood supply.
Leading to
Patellar devascularization, AVN, a vascular necrosis. It's a disaster. So gentle lateral release, if any, with a medial approach.
That is a hugely important safety tip.
Okay, right. Main event time, sequential soft tissue release. You said it before. Successful valgus TKR basically lives or dies by how well you manage these soft tissues, getting that nice rectangular gap in both flexion and extension.
Absolutely. It all comes down to a predictable, systematic approach. And for that, we really rely on the Ranawat inside-out technique.
The Ranawat technique.
Yeah, it's a very disciplined 7-step sequence.
Yeah.
It's designed to bring the knee back towards neutral alignment bit by bit, incrementally, without causing these sudden, big, uncontrolled shifts that could yank on that peroneal nerve.
Okay, walk us through those 7 steps.
Yeah.
Why is the sequence itself going from sort of superficial to deep? Why is that specific order so important? The order is key because it minimizes unnecessary damage
Yeah.
and lets you constantly check your progress, check the balancing.
Makes sense. Step 1.
Step 1, get rid of the obvious bony blocks, the osteophytes.
Yeah.
Clear those out first.
Okay.
Use an extension block or maybe a lamina spreader to gently put some tension on, targeting any remaining tight bits of the PCL and the posterior capsule. They might still be holding things tight.
Got it. PCL posterior capsule.
3, then you address the posterolateral capsule.
Posterolateral capsules. Okay.
Now you move to carefully pie crusting the ITB, the iliotibial band, little nicks, not a full cut.
Bicrusting the ITB.
After that, it's still tight. You release the LCL, the lateral collateral ligament.
LCL.
6. Next layer deeper is the popliteus tendon.
Popliteus.
And 7. Finally, only if absolutely necessary for balancing, you might release part of the origin of the lateral head of the gastrocnemius.
Lateral gastroc head. Wow, okay, that's quite a sequence.
It is. And following that sequence lets you figure out exactly what structure is still causing the tightness at each stage.
So how do you know intraoperatively, okay, is it the ITB that's the problem or is it the popliteus? How do you differentiate what's tight in extension versus flexion?
That is your crucial decision point during the release.
Yeah.
If you've done your cuts and the knee is balanced in flexion but still tight when you bring it into full extension,
Tight in extension.
then your main culprit is usually the ITB. So you focus your release there, more pie crusting.
Okay, ITB for extension tightness.
But if the knee feels balanced in extension, but then gets tight specifically when you flex it up,
Tight in flexion.
then you need to look deeper.
Mm-hmm.
The structure primarily responsible for flexion tightness is the popliteus tendon. So that becomes your target.
Got it. ITB for extension, popliteus for flexion. Now, when you're doing that ITB pie crusting, you mentioned avoiding big cuts. There's that infamous triangle of danger, right, where the peroneal nerve is hiding?
Oh, absolutely. You have to be acutely aware of that anatomy. That triangle of danger, it's roughly formed by the posterior edge of the ITB itself, the cut surface of the tibia below, and the popliteus tendon running obliquely.
Okay.
The nerve is typically running just posterior to that zone. So your releases, your pie crusting, must stay anterior to that posterior ITB border, working from inside the joint outwards. The goal is controlled, gradual release, not aggressive cutting near that neurovascular bundle. Stay safe.
Definitely stay safe. Okay, speaking of nerves, let's use this last bit to really focus on the complication that keeps orthopedic surgeons up at night. Common peroneal nerve palsy. CPN palsy. It's got to be the highest stakes risk in correcting a bad valgus knee.
Without a doubt.
How do we best try and prevent it from happening in the first place?
Well, prevention starts with the basics, being really careful with where you place retractors, especially posteriorly. No direct compression on the nerve.
Okay, careful retraction.
But probably the single most important preventative strategy, backed up by evidence now, is considering undercorrection.
Undercorrection. You mean deliberately not making it perfectly straight?
Exactly. The data actually shows that leaving a little bit of residual valgus, say, up to maybe 6 degrees, it doesn't seem to negatively impact the long-term survival of the implant or the patient's functional outcome.
Interesting.
But what it does do is dramatically reduce the amount of stretch placed on the CPN during the correction. And often that slight undercorrection means you might avoid needing a highly constrained implant, like a CCK or hinge, further reducing risk.
So aiming for slight undercorrection is actually safer for the nerve.
In many cases, yes. It's a very important concept. Prioritize nerve safety.
Okay, but let's say, despite everything, you suspect a CPN palsy right after surgery. Patient wakes up, foot's floppy. What's the immediate, emergency checklist?
Right. Immediate action is crucial. First thing, get any compression bandages off immediately.
Remove compression.
Second, flex the knee. Take the tension off the nerve.
Flex the knee.
Third, splint the foot in neutral. Prevent an equinus contracture from developing.
Splint the foot.
And finally, fourth, get an urgent X-ray. You need to rule out any obvious mechanical cause like a blob of cement pressing on the nerve. Or maybe the prosthesis itself is overhanging laterally and causing pressure. Things that might need immediate surgical revision.
Check X-ray for mechanical issues. Got it. And what's the usual outlook? If someone does get a CPN palsy after TKR, is it likely permanent damage?
Thankfully, most often no. The majority are neuropraxias, nerve bruises, or stretches rather than complete transections.
Okay, that's the news.
For those incomplete palsies, the neuropraxias, something like 2/3, maybe 66%, will see complete recovery, often within the first 3 months or so.
2/3 recover fully from incomplete palsy.
Yeah. And even if it looks like a complete palsy initially, studies show nearly 40%, 39% still achieve some degree of complete functional recovery eventually. So the initial plan is usually observation, physiotherapy, and supportive splinting. Wait and see.
Okay, observe and rehab first. But what if that foot drop just doesn't get better? It's persistent. What's the definitive long-term fix then?
If it's clear there's no recovery and function is impaired long-term, then you're looking at a salvage procedure, usually a tendon transfer.
Tendon transfer. Which one typically?
The most common is transferring the tibialis posterior tendon. You reroute it through the interosseous membrane between the tibia and fibula and attach it somewhere on the top of the foot, often the navicular or a cuneiform bone.
Using the tib post to lift the foot.
Exactly. You use that healthy, strong muscle to restore active dorsiflexion. So really, if we try to boil down this whole deep dive, managing that valgus TKR in an RA patient, it really hinges on anticipation, doesn't it?
Good word. Anticipation.
Success comes from really precise pre-op planning, especially those meds, compensating for the bad bone, probably with stemmed implants like a CCK or hinge, nailing the femoral rotation using Whiteside's line, and then executing that super meticulous step-by-step Renoir soft tissue release.
And crucially, having the wisdom, maybe the restraint, to slightly undercorrect, putting nerve safety potentially ahead of achieving that perfect zero-degree mechanical axis on the X-ray.
Precisely. Nerve safety is paramount.
And look, this level of detailed understanding, knowing the Ranawat steps, knowing the medication pitfalls, the CPN risks, this isn't just exam fodder. This is what separates a safe, competent surgeon from potential complications when you're actually facing these really challenging cases in the operating room.
Absolutely true. And we should just remind everyone one last time that the framework for this detailed discussion came from those excellent Ortho Made Simple notes, which you can find on the website mokyingren.sg.
Definitely check those out. And as you head towards your exams and, more importantly, towards managing these complex patients, we really encourage you to approach every case with the utmost diligence, skill, and, importantly, compassion. There's a passage that comes to mind from Proverbs 12:10. Whoever is righteous has regard for the life of his beast, but the mercy of the wicked is cruel. Now, obviously, patients aren't beasts, but the principle holds.
That deep sense of responsibility.
Exactly. May your meticulous preparation, your grasp of the Ranawat sequence, your careful CPN assessment, even your consideration of undercorrection, may all of that reflect your profound regard for the life and health entrusted to you. Go out there and practice diligent, compassionate medicine.